Hi, Lindsay.
Hi, John. Hi, Jonathan.
How are you?
Um, I'm I'm fine. I'm interested in the CIT presentation at 6:30. It's gonna be my first time talking in front of law enforcement at the end of March, and I'd like to hear the HHS take on it. So I'm fine.
Glad
Thanks.
you make it. Hey, Jen, did you know the Davis High School soccer team is ranked number 3 in the United States?
I did not. I just saw a headline today and hadn't had a chance to read it. That is so exciting.
Yeah,
Go Blue Devils.
I know, right?
Yeah.
Number 2 in California, number 3 in the US.
Wow.
Wow.
Oh my gosh, that is huge.
Yeah.
So who's number one in California?
Oh
If
God.
you're paying attention, I don't know.
I think some team in Southern California.
We're coming after them though. We're gonna bump them out.
I know, right? The keeper for the high school team is the keeper from Dylan's travel team.
Nice.
All right, I think we're going to get started. Nikki is here, so that means we can start. All right, it is 6:02, so we'll call the meeting to order, and we will start with public comment. We will have opportunities for public comment throughout the meeting. So if there's something someone wants to discuss in general, they can. There will be more opportunities later. I want to just mention that public comment is limited in time and is meant for comment and not for questions that are expected to be answered, although every so often we will answer a question, but generally speaking, it's not to answer questions. So are there any public comments? Seeing none. And if I say seeing none and I'm not missing someone, just shout out. All right, so approval of the agenda. Can I have a motion to approve the agenda?
I move we approve the agenda.
Nikki?
This is Maria, I'll second.
Maria seconds. Thank you. That's really helpful, Maria. So if you move to do something, if you say your name, that would be great and make it very easy on Christina. Right, Christina?
Yes, thank you.
Yes, okay. All right. Do you want to do a roll call vote?
Yes, Maria,
I'm here, yes.
Nikki,
Here.
Serena,
Here.
Sue,
Here.
Warren, John, Jonathan,
Yes.
Carol, Robin,
Here.
Brad.
Here.
I know everyone was saying here, but I just want to make sure that you knew that was for the approval of the agenda.
Yeah, I was gonna say, she need to say aye.
I'm sorry.
That's
Yeah,
okay.
Nikki, you started a trend.
I know.
Well, I think you said roll call, so I guess.
Yeah, and roll call to me meant here.
Yeah, same.
Yeah.
Okay. Okay. So item 3, approval of the minutes. Motion, please.
I'd like to get a correction in.
Okay.
My name isn't listed on either of those present or those absent, and I checked my notes, and I was absent. I had a migraine last month, so if you would, and I had notified you.
I will. Yes, you did. Yes.
Yeah. So, thank you.
Any other corrections? All right, I'll entertain a motion.
I'll make a motion to approve the minutes.
Maria, okay.
This is Brad, I'll second it.
Roll call vote.
Maria,
Yes, aye.
Inesita, Nikki,
Abstain.
Serena,
Aye.
Sue,
Aye.
Warren, John, Jonathan,
Aye.
Carol, Robin,
Abstain.
Brad.
Aye.
Your motion is passed.
And are you getting Chris on there, Christina?
Oh, Chris, I'm so sorry.
Chris is probably an abstain since he wasn't there.
Yes,
Okay, abstain.
I will add you. Thanks, Chris.
Okay, so you're probably all saying, who is Chris? And as the chair report, I'm just going to start off by introducing Chris Bulkley as our newest member. And I'm going to actually let Chris introduce himself.
Thank you. I was asked to join because you're looking for a person who is a veteran. I retired from the United States Army Reserves in 2012 as Lieutenant Colonel. I have 2 tours in Iraq. I also work in the DA's office. I have a lot of background with the mental health side. I help set up our mental health court. I run our diversion programs. And I see a number of faces here from HSA that I work with regularly. I'm looking forward to participating.
Thanks, Chris. And for those of you that don't know, the statute for local mental health boards was recently amended to require 1 member who is representing veterans. And that Chris, appointed by Supervisor Provenza.
Welcome, Chris. Are you related to the people for whom the street Bulkley Drive or road is named?
I don't know. It's spelled differently. There's a E that's missing on
Yes.
the street. At least there's one south of Davis that's kind of in
Yes.
the middle
Yeah.
of nowhere.
Yeah.
I don't think so, but
Okay.
you never
Just
know
asking.
how distant relatives are out there.
So I am attending from Monterey, and I am at a conference. It's a judicial conference of collaborative courts. And I was asked, along with actually Judge Rosenberg from our county, to sit on a plenary panel on mental health court. So I think Dave and I were among 5 panelists who sat on this panel, and it was quite a large crowd, many from out of state. So I just want to say it went very, very well, and I got to be the mouthpiece for all the great work that Nikki did.
That's such an organized crime kind of work.
I got to be the mouthpiece. I say that because all I did is speak about what we are doing in Yolo County with mental health court. I started off by saying that I'm going to sound like I'm bragging about what we're doing in Yolo County, and I am, but we're not perfect because we have significant issues in Yolo County in the area of reentry and housing. But what we're doing in the mental health court area with our partners, Health and Human Services and probation, and all our folks at the DA's office and public defender, and the conflicts panel and the sheriff and Communicare is pretty amazing, and it went over very well. So Yolo County once again is on the map. So it was really nice, and a lot of people appreciated what we're doing. So thanks for everyone here's contribution. It's really appreciated, and I think it's recognized across the state and beyond. So thank you. All right, member announcements. Any member announcements? Raise your hand or wave or anything you want to say. I got Brad.
Has anybody heard about if there's gonna be a memorial for Bob Shalin?
So I have not heard anything since the last meeting, and maybe someone else has. Sheila just popped on. I'm wondering if she knows.
Oh, well, I have not heard anything, but I do know that we are keeping an eye out for that. So I will definitely let this group know if we find out something, but thanks for asking, Brad.
So I'm just getting the feeling that probably as this has nothing to do with Bob, but I'm getting the feeling that there might not be anything that is happening, but if there is, we certainly want to be a part of it. And thank you for asking about that, Brad. And Nikki has something to add.
Yeah, I was just going to say, with his sister's death following so closely on, I mean, she might have been the person we would have connected with to see if there was going to be a service. But the fact that she died like within a few days of his death suggests to me there might not be any relatives close
Right.
planning anything.
Mhm. There are some identified relatives, and we have been,
Oh,
our office has been in touch with them, but nothing has been organized yet.
all
And
right.
I also wanted to be in touch with, because we thought that perhaps the Odd Fellows would do something. So maybe
Right.
I'll check in with them.
Okay.
All right. Thank you
you.
so much, Sheila.
That's
Thank
very
you.
sad to hear that his sister passed away.
Yeah.
He was a very, very kind, good man, I thought.
Yeah. And thank you, Sheila, for keeping tabs on this. And thanks, Brad, for bringing it up again. Any other member announcements? All right. Do we have any correspondence, Christina?
We did not receive any correspondence.
Okay. Today is the Carlene Jakowski show. And she's like, no. So we're going to start with, and I know she has some of her staff are here who are going to assist her with this presentation. And I know many of us are interested in hearing about it on crisis intervention. So Carlene, take it away.
Thank you so much, Jonathan. Christine, am I able to share my screen?
You are now, yes.
Okay, I will work on multitasking while I introduce. I'm very grateful to have Mario and Rob here. Mario is a HHSA clinical programs manager at Health and Human Services, overseeing access, crisis, and wellness. Rob Villarreal is a supervising clinician and oversees our crisis teams. And is the individual with HHSA that provides the CIT training to our law enforcement partners and helps coordinate that training with other folks who participate. So Rob will be assisting me with a portion of the presentation. Mario is also here to help answer any questions, but I'm going to start us off and let me pull this up. Can everyone see my screen?
Yes.
Okay, and then let me just start this from the beginning. Okay, so today we're going to go over our community crisis response program, and the crisis intervention team training is a portion of what makes up our larger crisis response program. So we're going to talk about CIT, which I know is something that folks want to hear about, but it's important to talk about CIT in the broader context of what crisis response looks like, because CIT, the training, is just a portion of what the larger crisis response model is for us in YOLO. I am going to briefly talk about the history of crisis response. I think to help put into context where we are today, it's important to talk about how crisis response has changed and adapted over the years, talk a bit about our crisis continuum in Yolo County, talk more about the community intervention program as it is now. Rob will go over the crisis intervention training modules. I will talk about our co-responder program. We'll review how the programs are funded, and end by talking about sort of what lies ahead and Crisis Now. So Yolo County, like many other jurisdictions, has experienced many transitions in our approach to providing crisis response services over the years. Some of these transitions have been the result of policy and funding shifts at both the state and federal level, and of course from lessons learned through each iteration. I'm going to briefly highlight some of our local history before sharing more about our current model. So since 2008, Yolo County has funded crisis intervention training for local law enforcement partners, dispatch, probation, and others using the Memphis model which is provided at no cost to partners. In 2014, Yolo County was awarded, oh, hold on. Oh, okay. I thought, do I have to do the waiting room or can you do it also, Christina?
I got it.
Okay, thank you.
Yeah.
That's really going to throw me off if I have to admit people while I'm talking too. Was awarded SB 82 grant funding to embed crisis clinicians with law enforcement. At the end of the grant period, the program unfortunately was not generating enough revenue to sustain the program. In 2017, Yolo County opened a mental health urgent care, which was open from 10 to 12 hours a day, 7 days a week. It was primarily intended for law enforcement drop-offs, but was open to anyone in the community who urgently needed mental health services. There were many lessons learned through that project, but ultimately it was not sustainable as intended. A major contributing factor to the ultimate failure of this project was twofold, we think. The location of the clinic, which was in a jurisdiction that is furthest from our jail and hospitals, resulting in a much lower volume of clients than was anticipated, and also some challenges in standing up Medi-Cal billing, which would provide consistent revenue to sustain the project. So all of this brings us to our current iteration of crisis services, which includes our co-responder program. So our current crisis services include access, 24/7 access and crisis line, which is contracted out. And our current contractor for the 24/7 access and crisis line is Heritage Oaks Hospital, which is located in Sacramento. We provide clinic-based walk-in crisis services, and we have our co-responder services, which are field-based services. So when we talk about our crisis response, we are talking about the co-responders, but we are also talking about a large amount of service that's provided in our clinic sites and walk-in services, including medication support. So this just is a little bit more detail about the community intervention program in the iteration that it was in from 2014 to 2017. So we had the SB 82 grant. We also leveraged MHSA and funding from law enforcement. The partnership included Yolo County Health and Human Services, a contract with Turning Point Community Programs, and our local law enforcement agencies. They utilized the CIT model. Some of the response to this version of the program was that law enforcement officers felt like it was vital to have mental health resources in the field, that they were able to manage mental health related calls, allowing officers to respond to more criminally focused calls, and that they observed better mental health outcomes. The current iteration of the program includes funding from MHSA, from our local law enforcement partners, and Medi-Cal reimbursement. The partnership includes Yolo County Health and Human Services Agency as a lead with our local law enforcement partners. We continue to use the CIT model and are providing CIT training. So the CIT training, which Rob will talk about in more detail, is currently coordinated through the Woodland Police Department. It is post-certified for the initial 40-hour training, more recently received post-certification for the 8-hour follow-up training, and also includes the presence of our co-responders with local law enforcement agencies on site, and they provide updates and participate in briefings. So I'm going to turn it over to Rob to talk a little bit more about the crisis intervention training. And this slide here shows the 40-hour training modules. Rob?
Well, thank you. Well, and it's quite a long and involved course. First off, we start off with it's a 4-day, 10-hour course that we start off with the introductions and overview of how county mental health and most operate. In the whole CIT post is to cover, because we do have law enforcement agencies and first responders from other counties, we try to make this a standard training so they themselves can go ahead and return to their counties and look at those agencies and incorporate them in the things that they do. But the focus is primarily for Yolo County law enforcement agencies. So part of that is we look at gathering individuals out in the community. Jen Danzer, thank you very much. She's taken on the NAMIC portion and has attended some of the 8 hours, and we're moving towards the 40-hour courses to capture in the next month and in May. We also look at giving the officers an overview of the different severe mental illnesses such as schizophrenia, mood disorders, moving along with dementias, co-occurring disorders of substance use. We are going to have our homeless outreach team providing some of the homeless interventions and some of the resources, helping the officers understand what's available out in the community and how to help those individuals connect to services. We do have peers that do have lived experiences that have had law enforcement involvement come and provide, which I think actually the officers have voiced is probably one of the most enriching things for them, is to talk with the individuals with those lived experiences, find out what they've gone through and how they have benefited, or what obstacles there might have been in accessing services. And so the officers have given feedback that that's one of the most important things that they've received from the CIT training, is that peer interaction, individuals with, whether it's family members or the clients themselves. The other instances that we do have, the different agencies throughout the community. We have social services, we have veteran services coming in and tell the officers how to access veterans resources, helping them connect with Mather or McClellan, helping them be aware of what times and where the locations are now. That's changed from Main Street to the Bauer Building for Veterans Service Officer, and how or what services they're able to access individuals out in the community to come in and connect with those veteran service officers. We've reached out to Woodland Memorial. We're going to look at having emergency room staff participate in some of the discussions, so they're aware, the officers are more aware of what the process is, bringing individuals into the hospital, what that experience is like, so they can go ahead and help prepare those individuals out in the community as to what that process is, to make it a less traumatic experience, and also helps the officers understand how the mental health process as far as admission to discharge goes. We have an older adults component. Part of what we're going to be doing this time is including APS in the process, so they can understand and appreciate more what APS as a agency, what they provide to the community, how they serve that population, and how to better interact with law enforcement, or how the law enforcement to better interact with APS in helping those individuals that are on the fringes or at risk older adults. The co-occurring disorders, we focus on some of the current issues, such as the fentanyl pandemic or epidemic right now. We focus on clarification of either major mental illness or co-occurring substance-induced psychosis, and help the officers to better understand the differentiation and the outcome potential. We also have in lesson 12, the excited delirium, implicit bias, as part of the process in which officers respond to calls, and how to transition from that general law enforcement response to more mindfulness approach, for the officers to be more prepared to go ahead and be present for the individuals, to provide that active listening and get away from any implicit bias, in which that in itself, law enforcement has many trainings for that, but I think it's a very good complement for excited delirium and implicit bias to be a combined training. We kind of move on also into a little bit of focus on the suicide risk assessment, the officer safety in regards to suicide by cop, managing stress, not only how to help individuals verbal de-escalation, but also for the officers to be able to be mindful of themselves and the impact of their jobs at home. Pastor Matt, one of the chaplains over at Woodland PD, does an excellent job preparing those individuals to really look at the impact of their work on their family and their family's impact on work. And that's something that's been very beneficial. we are going to actually, we're excited about having Alta California Regional coming in on the 40-hour course this year and providing in-service on the developmental disorders and the many access points for families to get support through Alta Regional, helping officers understand that, what services are available, how to access it. I think, matter of fact, we had an MDT when we had Alta Regional attend. I think Jonathan and Chris were on that meeting, and I think it was a very beneficial meeting to have Alta Regional really teach us a little bit more about the population they're serving and the programs they have.
Hey,
So
Rob,
Yeah.
MDT, what's MDT?
MDT is a multidisciplinary team which incorporates various providers, community resources, law enforcement, social services, mental health, physical health. All those individuals are involved in somebody's case, a client's wellness, participate in that MDT to go ahead and come up with a plan that client will be more that they have the buy-in to as well. And so we provide some what the Alta Regional team is going to provide for the CIT is a lot more comprehensive understanding of what the developmental disorders are and what the resources are. On top of that, the 40-hour course does a lot of role-playing, verbal de-escalation, that I think they've benefited from. So I'm not sure if anybody has any questions after that big rant that I just gave. But now the CIT, just to let you know, the CIT course here is modeled after the Memphis course.
Who are the instructors for the course, Rob?
So I'm primarily the instructor that does a lot of the introduction and overall welfare institution code. We do have some of our staff through HHSA providing some of the risk assessments, the verbal de-escalation. We have Woodland PD's chaplain participating. We've had CommuniCare staff providing with some of the substance abuse co-occurring disorder classes. We have NAMI, again, thank you very much. We'll have APS participating. So we try to get a broad overview of the different agencies and community providers. We are going to have the Fourth and Hope staff as well provide some overview of their programs. And I think that we are also looking at having we have DESS. I think that's, and again, we're looking at also trying to get the emergency room nurses to come in from both Sutter and Woodland Memorial to give us, again, the officers a good perspective of how that process goes when somebody's coming into the emergency room.
Thanks, Rob. That was very insightful presentation. Sue?
I just wanted to ask about kids. What kind of training do they get when the person in distress is a child or a teenager?
We are working right now. There is a developmental disorder component, but actually it's a little bit more comprehensive. We do discuss some of the individuals that might be dealing with autism or individuals that are in the foster care system. The developmental disorder is not only facilitated by Alta Regional, but one of our co-responders has extensive history working with children. And so she provides some of the in-service or instruction as well.
Thank you.
Nikki?
Yes. How this says that there's a 40-hour course that starts out. And at what interval is the follow-up training done?
The 40-hour course, and this is something that the law enforcement agencies in Yolo County have taken on.
Right.
as being something that every officer coming on that's new or transferring from a different agency is going to be certified for that 40-hour course. And then it is every 2 years, if I'm not mistaken, that the FTOs, the field training officers, will be going to the 8-hour refresher. Now it's up to that individual agency if they want their patrol officers also to go and have a refresher. But the 8-hour is a 2-year refresher.
Okay, thank you.
So for those of you that don't know, believe it or not, there is no requirement that POST has, that's Police Officer Standards Training, for officers to have this sort of training, but there is a requirement for the FTOs or the field training officers. Those are the ones that are training the newbies, basically. And I think that, you know, what's nice in Yolo County is all the agencies are requiring their officers to do this 40-hour course that Rob and HHSA is offering through Woodland PD. They're the sponsor, so to speak. And I think many of them also want their officers to do this 8-hour follow-up training. I don't know how often, but I know, for instance, Davis PD, the chief, Darren Pytel, his feeling was many of them had already done the 40-hour. Of course, they have some new ones that have come on in the last couple of years. But what he was really interested in is the 8-hour. So now, as you've heard, HHSA is taking the lead on doing the training for the 40-hour and the 8-hour. Sheila?
Thanks. I was curious, I see that lesson 10, there's 1 hour spent on older adults, and you said that you're working with Adult Protective Services, which is great because it's not only, it's very interesting what they can do, but I think equally interesting what they can't do. I am curious if there's any coverage of persons with Alzheimer's and dementia, which I know that's always been a frustrating thing for me, that it's not a mental health thing. They always keep it separate, but many of the interactions or the issues might be similar.
So what I've really come to understand with the 40-hour course, there is a guideline in which POST has set. And I think it's very important for the coordinators, for me, to understand, the audience that we're speaking to and really the information that they need. The original older adult course was primarily focusing on Alzheimer's, dementia, any age-related disorders, something medical-related, delirium, things of that nature. But I thought the officers could also benefit from the different resources, different providers that focus on the older adult population or dependent adults at risk. So not only are we adhering to the POST standards, but we're building on top of that. It's going to be something that's more meaningful, more useful for the officers out in the field.
Great, thank you.
Well, thanks. Go ahead.
Yeah, Rob, did you want to touch on the 8-hour follow-up course?
Yeah, the 8-hour, we're really looking at the focus again of the 8-hour on stigma and culture relevance. And jokingly, and not, I should say, it's nothing to joke about, but to get the officers to really understand, I bring them a dozen donuts, and regardless if they're on a diet or not, they're going to be there in front of that donut because that's a stigma that they're stuck with. So in relationship to the stigmas that our population have to deal with, the people that are dealing with mental health issues, that's something that they have a hard time escaping. So the focus is to get the law enforcement agencies, the law enforcement officers, to understand that the obstacles that the people that we're serving have to deal with, and to get them to see that from their perspective, the individual's perspective. I'm kind of reach out to Nami and Jen to, she was there for part of that 8-hour, and I think there was some good discussion, especially with some of the sergeants there that really want to know how they can reach across and become more involved, or have the population become more involved with what they are doing. And I think that, Jen, that they reached out to you and are trying to build on top of that. So the 8-hour course is, it's a little bit more intensive. It's a lot more collaborative. I think part of one of the things that we're looking at is we do go over the mental health disorders, intellectual disabilities, and substance use, but we also focus a little bit more so on the personality disorders. And when we're looking at responding to certain calls or co-responders, the different personalities that come in conflict with, domestic violence, or there's conflicts out there, how the officers can look at approaching certain individuals in a way that those people can be more receptive. So again, reaching out, getting something that's more useful for the officers to use as tools, and then also engaging in with different resources such as NAMI to get to have CIT evolve to more than just a training, but a community. And I think that's really the focus for CIT and the 8-hour.
Thanks, Rob. And it's, and Rob certainly is the expert around CIT, but just, my understanding too is that the 8-hour follow-up is an opportunity to do a bit of a deeper dive. The 40 hours sounds like a lot of time, but it is a short amount of time when you think about the breadth of information that you want to impart on our law enforcement partners, the topics you want to discuss, certainly the skills training and practice that comes along with it. And so to some level, there's a recommendation around tailoring your 8-hour refresher to topics that are really pertinent to your local law enforcement jurisdictions. And that might look different in different areas of the country, certain different areas of our state. And so, I think that what Rob's sharing too is that this has been a bit of a development process around the 8-hour follow-up to make sure that it is really relevant topics to YOLO and to our community. I see Nikki has her hand up, Jonathan.
Oh, thank you. Thank you, Carly. Nikki?
Is there any opportunity for officers who might be coming back for the 8-hour course to submit anonymously problems that they've had so that those could be addressed in the follow-up training?
Well, we try to bring as much real life situations as possible, keeping in mind HIPAA and all the different confidentiality restrictions that we have. Some of the officers will speak in generalities about some things that they might have come across. And we do our best, we actually do keep everybody's confidentiality at heart. So they do bring real scenarios in that we do discuss. And I'm sure if that answered your question.
Yeah, and perhaps that's something to consider. I think, Nikki, I hear you talking about an opportunity to sort of anonymously submit something, which there's some value there too, something that someone may not want to share, right? But they certainly could use it as an example. And, the scenario-based skill training is really intended to be based on real life scenarios that folks either have encountered or may encounter. And so I think bringing in the relevant real life experiences of our local law enforcement officers would be very valuable. And it sounds like that's something they're doing in the interactive components of the training.
Definitely.
Okay, Jonathan, if there's no other questions about the training, I have a few more slides just talking about the co-responders and budget and things like that. Okay, there may be questions at the end, so hang tight, Rob and Mario. We're almost done though. Okay, so I'm going to share some data about our CIT training. So in 2020, HHSA assumed responsibility for CIT trainings, but this unfortunately was preempted by COVID. In 2021, 20 of our local law enforcement officers received the 40-hour training. We trained 28 officers total. We had 8 officers from outside jurisdictions. Because these are post trainings, they are available online for local law enforcement or law enforcement entities to register for. And so we have had Pleasant Hill, Gilroy, Dixon come to our training as well. But we held a 40-hour training in August, September, and October of 2021. The Woodland Police Department and Yolo County Sheriff had folks attend in August. We had the Davis Police Department, Woodland Police Department, and Yolo County Sheriff attend the September session. Woodland Police Department, Yolo County Sheriff, West Sacramento Police, and UC Davis Police attending the October 2021. Now in 2022, we didn't hold any 40-hour trainings, and there's a number of contributing factors. In part, HHSA had some pretty significant COVID restrictions to in-person events that were imposed by our local requirements from our health officer, but also some state requirements as well. And there's a bit of like, if the training isn't posted, are folks going to need notify that they need it or register that they may need to register for it? There were no requests made either, so there weren't any 40-hour trainings held in 2022. There are 2 sessions scheduled for March and May. Rob, are those both 40-hour or are those 8-hour as well?
In March, it's a 40. In May, there is a 40 plus 4 additional 8 hours trainings.
Thank you. Okay, so our current co-responder program, I'll just sort of briefly share. Our co-responders are trained in behavioral health to effectively address crisis situations, allowing law enforcement to focus on public safety. Embedding our co-responders with law enforcement increases officers' ability to deal with behavioral health crises through consultation and observation of our co-responders' techniques. Co-responders save multiple systems money. They decrease hospitalizations, incarcerations, and free up officer time to address public safety matters. Our current co-responder model is one that's built on a close partnership with our local law enforcement entities. We have clinicians embedded within our local law enforcement jurisdictions. And while we do not have 24/7 coverage with our current staffing array, we have structured the co-responder schedule to be responsive to the needs of each jurisdiction. At this time, we have 6 FTEs dedicated to this project, 1 co-responder assigned to the Davis Police Department, 1 co-responder shared between the Sheriff's Department and Probation, 2 co-responders assigned to the West Sacramento Police Department, and 2 assigned to the Woodland Police Department. There is interest to add from one of our local police departments to add at least 1 co-responder in next year's budget. So that's something that we're discussing and planning for fiscal year 23-24. Lack of sustainable funding was the demise of our past responses or approaches to crisis response. What is unique about our current model is that there's a cost sharing arrangement between the Health and Human Services Agency and our law enforcement partners. Our law enforcement agency partners and YOLO's Community Corrections Partnership, CCP, pay approximately 50% of the staffing costs for each co-responder position, and the remaining staffing costs and administrative support and overhead are covered by HHSA. Now, on the HHSA side of funding, we leverage MHSA to fund these positions. We also draw down Medi-Cal whenever possible, but they are primarily funded through MHSA. On the horizon for YOLO is the addition of peers to create co-responder teams comprised of clinicians and peer partners who have lived experience. These additional peer positions will be fully funded by HHSA, leveraging MHSA funding. And those positions, I believe have already been created. Mario, is it accurate that we just haven't filled those positions yet?
Correct. We have a recruitment actively right now. We're setting up interviews shortly.
Great, thank you. And then additionally, we're working toward implementation of Crisis Now, which I will talk about a little bit later. I wanted to share some photos of our specialized crisis response vehicles in case folks hadn't seen these. So these vans.
Hey, can I ask a question?
Yeah, sure.
Yeah. So, and this you may get to later, but so from the training I've done, and I'm an expert like all of you. I just know enough to get myself in trouble. But the Platinum model is the crisis response team, where in most situations, cops don't even go out to the scene, and they work with a team to see if it's necessary for public safety reasons if they go out. So the co-responder model is not the best model, but it's a good model and way better than what we had before. Is there is the plan as we move forward with Crisis Now to go to a crisis response model where a good majority of the costs will not even be responded to by cops except only when necessary.
I think that's the hope. I think, but something that we're also balancing is the feedback from our local law enforcement partners who do not want to see the co-responder positions go away. So we're balancing the experience benefits that our local law enforcement agencies are sharing about having that co-responder role. But you're right, Jonathan, the gold standard is to have crisis teams that are comprised of a clinician and a peer, and that calls that absolutely do not require law enforcement response are only responded to by the clinician and the peer. There is a lot of feedback that we've heard from other jurisdictions who have implemented different iterations of these mobile teams and crisis response. There is a lot of feedback around how to, or the need to really support the training, support, and debriefing really with peers in particular who may not experience through education, knowledge around secondary trauma and how some of the situations that they may encounter out in the field can impact them. And so we have heard feedback from some counties or entities that initially had clinician peer teams going out who have actually sort of scaled back what some of the peer role is. So I think for us, it's really going to be important to stand up the peer component of the model with a lot of support and supervision for our peer staff, and really supporting them and understanding that these are very difficult situations. I'm not sure if folks are aware, but our co-responder clinicians wear bulletproof vests while they're out in the field. It is a very different kind of clinical role than a clinician who's sitting in an office and assessing clients in a mental health clinic, even dealing with crises in an office setting. Being out in the field and responding with law enforcement officers really adds this different, feeling, I think, to the work, and certainly a different level of safety concerns for our team. So there are definitely different things to consider. So I think in our mind, our dream model would have all of it. We would have some co-responders who are embedded with our local law enforcement agencies. They can participate in briefings. They can help provide some education. They can provide co-responder support when needed. And the gold standard model that you're referring to, Jonathan, also says that if a co-responder is going out, they need to go out with a law enforcement officer who's been trained in CIT. And so ensuring that that training is happening is really critical to the model really working. But that we would also have mobile crisis teams that could be deployed from anywhere in the county and not require that co-responder response. And certainly when that's the most appropriate intervention and when it's safe to do so. And we do believe that there are far more situations where that can occur, and that we can be able to deploy crisis clinicians and peers and other kinds of supports out to support folks who are having mental health crises and not involve law enforcement at all. So we're looking forward to getting to sort of that version of our approach.
Thank you.
You're welcome. Okay, so these photos here are the specialized crisis response vehicles that our clinicians use to respond to calls and provide immediate crisis services in the field. For YOLO's model, our co-responders do not respond with law enforcement in their vehicles. In some jurisdictions, co-responders are in police vehicles with the police officers or in sheriff's vehicles. But for ours, they are meeting them on location in our specialized vans. So they arrive on scene in these vans. The vans have been modified to provide for a comfortable space to conduct mental health assessments, complete paperwork and documentation. Our co-responders have noted that they appreciate being able to stand up and walk around easily in the vehicle. They have found these vehicles to be effective for their roles. With some modifications needed, sometimes I've learned a lot just in the time I've been in this role and being able to tour our vehicle with one of our co-responders. Maybe Rob or Mario can tell me the name of it. There's some special contraption we have to get that attaches to the air conditioner in the van that then they can put on themselves, because when they're wearing the vest and they're in their full gear, it's quite hot, especially in summers in Yolo County. So there's some specialized things. They've noted some things that they'd like to have in the vans that might help with safety and some other things. But they really have noted that these are really great to work in, provide a great space to provide this in the field response, and they're really ready to go at any given time. So they can be sitting there and working on documentation or working on their computer, and then they're able to just get in the van and go when they're getting called out to a call. Okay, so these next few slides, I'm going to share some data. And these are just going to highlight several data points that we track as we assess the success and challenges of this project. What's notable here is just to note that we have grown this project over time. And with more and more time into implementation, we are experiencing an increase in utilization of these services. The majority of the calls to our co-responder team are to assist with an immediate crisis, about 58% of our calls. By crisis, we're referring to any behavioral health crisis when the reported party is thought to be in urgent distress and needs intervention to prevent escalation. 28% of the calls are related to mental health needs, meaning the reporting party is not, or the reported party is not in urgent distress, but needs linkage to mental health services of some kind to prevent escalation to a crisis. Okay, question?
Yes, and I'm not trying to be a pain, but what I see in this data here is that you're covering just about 18 months. We are, almost 15 months past that time, and I'm wondering if the increased utilization had something to do with COVID and if we've seen it tail off since then.
It's hard to say because we implemented this model in 2020, so we have any real comparison, right?
No, but you've got forward comparisons, right?
Sure, yeah, at the time I put together this, we actually didn't have the other data ready yet, and so I suspect that I can share some. I can look at more recent data and share some comparisons in a follow-up. But this is. I can't speak. I don't know if Rob, Jenny, or Mario any insights into utilization.
I think in regards to the trend in COVID related, I think the law enforcement officers, the agencies could probably speak to the same. Is that there are increased calls for service that seem to be individuals that are having a hard time acclimating back into society, getting back into the jobs, back into the community, back into social networks, that we're having increased calls that seem somewhat related to that. So there are individuals that are having a hard time coming back into the mainstream. So we do have increased calls.
We also added co-responders during this time, so the program has grown a bit, and so we also had our fullest a number of dedicated FTEs. We do have some vacancies, and so again, with full staffing, I think you see differences in our data points as well. Let's see. This slide highlights a few additional data points, some notable. Oh, sorry, let me go back here. Some notable data points here that a majority of our calls come from law enforcement, which makes sense considering the nature of this partnership. Additionally, only 1% of the calls our co-responders have been called back to have resulted in an arrest, and 7% of those calls have initiated in a 5150 by a co-responder clinician. So we have a low rate of 5150 holds being written, also a very low rate of arrests occurring under in the co-responder situations. This next slide here, I don't expect you to be able to read it, just your eyes. Probably to see this. I certainly have to. This is just to show you what the data dashboard that we are using to track data points for this project. So these are, and I pulled some of those out on the previous slide. But these are all different data points that we are tracking. So other metrics that we track include number of calls per day, duplicated individual served, time on scene, and mental health substance use disorder, and housing services referral and linkage. Okay, this next slide here is some information about our budget. I shared earlier in the presentation. When we talk about our crisis response program, we are talking about CIT training. We are talking about our co-responders who are embedded with our local law enforcement agency. We are talking about other crisis services that include walk-in clinic crisis staffing, crisis medication support services, the contract that we hold with Heritage Oaks Hospital to provide after-hours crisis navigation, plus overhead. A few things to note looking at this spreadsheet here. There's a bit of a data issue for the one of the budgeted amount, I think 22-23 budget and the 21-22 budget. The actuals are accurate, but we do have a little bit of a variance that I'm working with our fiscal department to confirm. But what is accurate is the total MHSA plan budget. So that line there that shows the total amount that we dedicated in our MHSA plan for each of these components, which total to our crisis response program. The MHSA plan budget may also include additional overhead and costs that were not accounted for in the above line items. In terms of revenue, our local law enforcement entities contribute $60,000 per co-responder clinician. And so you see there the LEA contributions of $300,000. And in fiscal year 21-22, we generated $339,000 of Medi-Cal revenue. So that offsets what's budgeted in MHSA. So anything that we draw down Medi-Cal revenue for, we offset MHSA. So that comes, we don't spend that MHSA, and we account for those dollars that I'll draw down.
Question? And this is something you and I have talked about before. So I know that. So one of the things that I've appreciated about what you have done in your short time in your position, interim and as permanent, is we all learn from mistakes, and you've been willing to or mistakes or things that could have been done better. I don't want to say mistakes, and you've been willing to pivot, which is hard to do. Like safe harbor and things like that. So this is something that I've mentioned to you on a side note. I know that there was contributions required from the cities, which you just mentioned, and the cities are pretty strapped as the county general fund. Like if they had to put in money for the sheriff's office and probation for their for this work. Why is it when we have, and maybe I just always over exaggerate how much money we have in MHSA. I just feel like we have a ton of money. I know a lot is spent, unlike a lot of counties, but every year a lot is unspent. And so my question is, why are we requiring this contribution by the cities? For the co-responder. I know in the past what I heard is we wanted them to have skin in the game, but they're invested. And so do you think that it's necessary? And do you think that we can't cover those costs? And if we do increase the hours, beyond 40 a week or 80 a week for some agencies, can we do it with the MHSA rather than having cities have to put money in?
take some of it. So I think the answer is yes to all of it. I think there is a benefit to having a shared responsibility for some of these collaborative partnerships. In my experience, it can help with, and you said it, they're bought in, they see the benefit, there's no doubt. It's evidenced by the fact that they want to add co-responder clinicians, they don't want those positions to go away. There's definitely no concern for me about the engagement or participation in this collaborative project with our local law enforcement entities. And I can make guesses about why it was maybe required or asked for. I don't actually know if it was required when this project at its inception. I was not in this role at that time. But I suspect that some of the thinking is also that when there is blended funding, it can help with sustainability of a model. So what's unique right now about our co-responder program is that because there is some blended funding, law enforcement agency contributions, and a lot more that's supported by HHSA, because $60,000 a year doesn't actually cover 50% of the total cost of salary benefits for clinicians and also overhead, especially like vehicles and other things that we are responsible for. But it helps to provide some very funding. Now, and if you're right about MHSA, we have a significant amount of fund balance that we need to spend down. And we have experienced increased revenues of MHSA over the last several years, and we're projected to continue to increase revenues of MHSA this year and next year. However, 2 years out, they're projecting a $2 billion decrease in MHSA revenues across the state. And I worry about scaling back on blended funding for multiple projects. This isn't the only MHSA project that has blended funding. For example, we have a partnership with Woodland Community College where they contribute some funding to the project, and with MHSA, we have a K-12 partnerships project that leverages other funding, the grant funding, and MHSA. And so the potential sustainability of models that have additional funding, it gives us some extra security, I think, when we do, if and when we do experience this potential economic downturn, but certainly a decrease in MHSA revenues. My personal opinion, my position as a health director now in Miller County, is I never want to stand up a program that I know they're going to be able to be sustained. I think it is our community a disservice to invest resources and stand up services that then go away when they're at the time limited need, and the need goes away. Then great, but most of the services that we offered over the years, they need to go away. There is a need for mental health urgent care. It's not that they went away. We couldn't just fiscally sustain a model. So I'm really interested in fiscally sustainable models for programs. And so the short answer to my very long-winded answer, Jonathan, is yes, we could support the full cost of these positions with MHSA. I'm certainly open to exploring it. I do worry about if and when we have a significant decrease in revenue, and hopefully ideally has set down our fund balance, then what? In terms of the daily so states do gain quite a bit from having on-site consultation, training, written 5150, whole application to benefit them, and not necessarily clients directly. So there's a direct benefit for our law enforcement partners as well for the resources that they get from those co-responders being embedded. And we do track those additional benefits through our RBAs for this project. And I think the last thing I'll say is that we are in a position where we feel like our salaries for clinicians and supervising clinicians is inadequate. We have lots of vacancies with clinicians across our agency, but we have experienced turnover for these co-responder positions as well. And so we are exploring what potential we might have to add funding for especially these co-responder positions. So we have to get creative in how we're able to do that because these are currently classifications that are used very broadly throughout the agency. But if we were to increase salaries, we would sustain the increased costs in totality through HHSA. We would not extend those additional costs to our law enforcement partners. And we do expect to have increased salaries as soon as we can work with county HR on a solution which we're in the process of doing. I don't have anything else really to say about budget here, other than that the budget amount for fiscal year 22-23 includes a significant amount of money that was set aside for crisis now implementation that has not been spent, and that will not be spent during this fiscal year due to the significant challenges that we've experienced with that program and program delay. So I do just want to note that a notable increase to the budget for this year, but that is almost fully related to crisis now and funding that is set aside for crisis now. Any other questions on budget before?
Any other questions on budget from the members? I'm going to get to public comments after. Scrolling.
Can I just ask a little bit about, you were mentioning a little bit about retention and having some overturn. Have you guys done an analysis of what the retention reasons were? Were they something that were under departmental control? Like, because one thing I know about crisis positions, they're very difficult. And has that been a problem for your retention? And have you guys considered like maybe a rotation for people or something like that? I'm just trying to think about retention is our most important thing, I would hope. And so did you guys do an analysis of that?
Yeah, that's a great question. I would have to defer to Rob and Mario about, it is a small number of positions. And so I think anecdotally, I don't know if you can share some feedback about, in general, some of the reasons that folks have left.
Mario, you can go for that one first?
Basically, it's the competition with the salaries and outside counties are surrounding us.
Yeah. So Mario, or any of you, and I Carly and I talk a lot about this stuff. We have a problem in Yale County competing with, unfortunately, in Sacramento and Solano. But like, this is a specialized area where we have people working, 24/7 potentially if you have to do it right in our world. I guess it's more posing something than asking for an answer. But could we offer? I know in the county we're all looking at recruitment and retention. Everyone, Carlene, Mario, we're all looking at how do we recruit people, retain them. We have to do things differently because we're not going to offer the salaries Sacramento does. But can we, for a position, I know we have to be consistent with our social work positions, let's just say, but could we offer like a differential? Is what they're doing is so different, and they're wearing, creating bulletproof vests.
Yeah,
which is the stress.
Absolutely. Yeah, thank you, Jonathan. That's actually something we're currently working on. So Mario and I have been working with Nolan Sullivan, our agency director, on doing some research for other counties that we are certainly losing folks to, or that we are even having a hard time. We have a vacant co-responder position. We had an excellent candidate, but coming from another county that pays much more, so the pay cut was too significant. We were unable to hire the individual. So some of what we're looking at, this gets into a little bit of like county dynamics, but we are very rigidly bound to salary schedules and how folks are paid. And so currently our co-responder clinicians are working under the same classification as other clinicians. Now, my opinion, like Jonathan just shared, and if you just alluded to, Robin, is that our co-responders actually have a very different job than a clinician who's sitting in the office, or even some of our clinicians who maybe provide field-based services, maybe someone who's a clinician for a full service partnership or something like that. The nature of the work they're doing is significantly different. And even for Rob as a supervising clinician, the nature of what he's doing is is different than other supervising clinicians. So there's a couple of ways that we're proceeding. First of all, I think our salaries for clinicians and supervising clinicians is low across the board, even for folks who are providing office-based work. And so we have requested through county HR a number of positions to be a separate cost and comp. We provided some comparable salary ranges to share to help sort of hopefully move that process along. In addition to that, I either would like to create a specialized class classification for co-responder clinicians that has a different salary than a clinician, or provide a pay differential on that side. So pay differentials can be provided, probably happen through the MOU process, because we have to remember we're in a unionized environment, so we have labor relations, so we need to work with the unions on something like that. So we are working with HR to figure out the best path forward around that, but it's certainly something, that a ball that we have in motion, and something that I'd like to see accomplished sooner than later. I think when I say that, I speak for myself, Rob and Mario, that we would like to see those pay increases, and certainly some kind of pay differential. They're also working shifts that are not maybe ideal, right? They make work well for them, but they're not ideal. So these are also hard positions to stay over a long period of time. You have folks working their regular shift until 10 p.m. You have folks regularly working every Saturday and Sunday. There are impacts to your life, to your social life, your family, their families. And so these are difficult positions to sustain. And like we said, they're also just a very different kind of work, a very unique and specializing person really wants to do that kind of work. Not every clinician wants to put themselves in that situation. In fact, I'd say a very small percentage do. So we happen to find some really incredible co-responders. Rob is wonderful in overseeing this team, and Mario's done an incredible job of supporting the work that they're all doing. Really proud of what we have, but I think that those are some of the things that we have in motion to try to shore up. And not even all of it, but we certainly need to be able to be competitive and to be able to I think adequately reimburse for the different nature of the work that's being done by this team. So we're working on it.
Arlene, I'm going to say, we say things that will get me in trouble, but sometimes turning HR is like moving like an aircraft carrier or a battleship. And I know we have Oscar on this call, so I hope he's listening. But I hope you take advantage of all your partners, meaning the DA, the public defender, and this body to help you in somehow influence or speed along to do this, because it's so important, because we're all behind you, right?
Yeah.
So, I mean, it takes a village, to make these changes because of union issues and everything. But, we have to differentiate it, and I think we can.
Absolutely.
And if we don't, well, that's on us, because if we don't do it, then we're going to be left with what we have. We're not going to be able to fill positions, and there's going to be a lot of people out there not getting the services that they need. So, so thank you.
Yeah, thank you. The last thing I want to say about budget before we launch on the side, we have a fairly small amount of money being both budgeted for and actuals for CIT training, and that's really because there's never been a lot of very specific dedicated resources to CIT. Rob is it, other than the time of staff for helping support the modules and the lessons. And so as I move into the next slide, what I hope for our USA plan and for next fiscal year in particular is to have an CIT training coordination, so we can elevate the training that's being offered, the coordination tracking, because just as a news flash, it's not actually supposed to be. Rob had already more than a full-time job including CIT. He supervises all of our co-responder commissions, our clinic-based crisis teams, and frequently provide crisis response services himself. I can attest to seeing him outside of my window talking to folks and de-escalating folks in the parking lot quite often. And so, so we have not really dedicated staffing to support this at maybe the level that I think folks are wanting from us, or certainly that maybe the need sort of rising to. And so Rob and Mario sort of put their heads together and made some recommendations, and so I certainly will be looking into how we can support that, ideally in our new 3-year MHSA plan. So our future goals, and just to talk briefly about crisis now, we'd like to add some dedicated staffing to support CIT training coordination, and that would ideally be through an outreach specialist too, which is a classification that we frequently use to do different kinds of trainings and to help with training coordination, and specifically even for some of our MHSA training that we provide under PI. Increasing our frequency of initial CIT trainings and ongoing development and implementation of the follow-up CIT trainings, integration of peers into our co-responder teams. So as Mario shared earlier, we have created those positions. They're fully funded. They're accounted for in the budget for this year, but we're working on interviewing and filling those positions. And then the potential expansion of our co-responder team with adding another clinician as one of our law enforcement jurisdictions may be requesting. And then also looking at the implementation of mobile crisis teams that are not necessarily co-responders, so that we have a full continuum of crisis response. And then our sort of next steps ahead are some reevaluation currently of the implementation of Crisis Now from the original vision, which was ambitious and with very good intentions, wanting to create the ability to do it very quickly. And I think what we realized through some of the preliminary processes that we've been going through is that a phased approach is probably what's more realistic, and that can start to help us start to get some of the components of Crisis Now in place. So what we're looking for now is a phased implementation, with phase 1 being the high-tech call center that have both 988 and 911 integration. Phase 2, piloting the receiving cares, so really creating that receiving cares model. And then phase 3 is the short-term crisis stabilization unit pilot, which are the short-term beds that then can partner with or sort of lead into those longer-term crisis residential stays that Safe Harbor currently provides for our community. And that concludes the presentation. This slide you've seen here, and you've seen in probably other places, some folks here, which is just those core elements for transforming crisis services that is really guided the Crisis Now learning collaborative work that happened over a year, and that certainly will continue to guide our implementation of some improvements or expansions to what is currently in our crisis array in Yolo County, and eventually getting to that vision that Karen, I think, so beautifully painted for us some time ago, and working hard to get there. So that concludes the presentation. I'll stop sharing so I can see more faces.
They may be like, they might be in all of these know how they run constitution and also doing everything.
That can happen, no, that's a bizarre situation. Once the on, and those ones in there, there's no working with the foundation or the allocation, then you have all the resources available, and it's open, and it's a larger institution. If you then do the anymore, and I'll just be running in, and also, that's the officer.
Especially with mental health, right? This is not important, and that's what I want to see, right?
Right, and there's been people really interested, so there's really going off with the Legal Center, or the Department of Development, much of that, they know our resources, we have a number of cases, Legal Center, or we know to use actually the resources.
All right, so any member questions? Seeing none, I'll do it. Thank you.
I Yeah.